This is a presentation beginning on Chapter 1, Preoperative Room Considerations, from the TEAR text. By the end of Chapter 1, which we are only beginning this week, you should be able to explain the ideal layout of a surgical suite and the adjacent areas, explain the cleaning of the equipment located in the surgery room. Yes, the equipment in the surgery room does need to be cleaned. Describe the function and components of an anesthesia machine. Describe the use of different oxygen flow rates and the indications for their use. You should be able to describe the method for performing a leak check on an anesthesia machine, unless of course you're just really happy to smell isoflurane or Sevo all day. Describe how to calculate the size of rebreathing bag that's to be used on a patient. Describe the use of different oxygen flow rates and the indications for their use, and list the common surgical instruments used in surgeries and be able to identify the common surgical instruments used in surgeries. When we begin talking about the layout of the surgical suite, we're generally talking about, in many practices, three areas. The preparation area, from there the animal goes to the scrub area, from there they goes to the surgery room, and logically enough after that they'll go to recovery. Many practices combine those into two rooms, and many practices use those as one room. But the proper, ideal, best, optimal is going to be three separate areas. When we look at the layout of the surgery room, certainly we need to look at the equipment. And we're going to look at non-movable or permanent equipment, things that are in there that you're probably not going to be moving out on a periodical basis, things that don't have wheels, things that weigh a lot, things that are bolted to the ceiling or the walls. And that would include most commonly surgery lights, which are not going to be able to be taken out very easily, the surgery table, which may or may not be very mobile, and certainly radiographic view boxes, which in many cases are mounted into or onto the walls. In this picture below, you see there's a surgery light, and in the background we have the X-ray view boxes mounted into the wall. Movable equipment, those things that you can get out of there pretty easily to clean and to get behind and to clear the dust bunnies from where they used to be, would include the anesthesia machine, your monitoring equipment, heating pads, IV drip stands, instrument tables, suction units, cautery units. All those are things that you can easily take out and either clean or clean where they were. And first rule is, if you don't know what to do, clean and organize, organize and clean. And we start with cleaning equipment in the surgery rooms. We want to maintain as aseptic an environment as possible. And it is disturbing to me that when I walk into a surgery room and I look around for a practice and I see dust bunnies in the corners of the surgery room, a layer of dust on all the equipment, and I'm thinking, not bringing my animal in here for any surgical procedures. In fact, I'm probably not going to bring my animal in here ever again. Just too nasty for me. We want to maintain aseptic conditions, we want to follow the manufacturer's instructions, and we want to use judiciously alcohol or other chemicals in accordance with what's going to be the best cleaning practices. For good or bad, you're going to get anesthesia machines over and over and over and over again. You're going to get them in this chapter, you're going to get them later on in the other book by Thomas and Lurchie. You're going to get anesthesia machines in some upper level courses. You're going to get large animal machines in large animal classes. You're going to get anesthesia machines over and over and over, and the reason for that is they're very important. Repetition is the mother of all competency. You can't know too much about anesthesia machines. The purpose of an anesthesia machine, as if you were probably not aware, is to deliver inhalation anesthesia to the patient and remove unneeded gases from the patient and the surgery suite. We are to deliver oxygen at a controlled rate. We are to vaporize a liquid anesthetic. We are to remove exhaled gases and dispense or dispose of them through an appropriate scavenging system. Everybody and their brother George makes anesthesia machines. There is just tons of them on the market. My particular favorite brand is Matrix. I like Matrix machines. They're simple, they're reliable, well made, last for years, easy to take care of. Love my Matrix. Drive Fords, buy Matrix, have my prejudices on things. All anesthesia machines are going to be the same. Regardless of who makes them, regardless of who the manufacturer is, they're all going to be very, very similar. In fact, I know many veterinarians have actually gone out and made their own anesthesia machines from various components of this and that, and they seem to work really pretty good. I've been impressed with a few of them. So all anesthesia machines, basically the same. Certainly anesthesia machines can have more than one vaporizer. Here's an example of a machine. Looks like it came out of a human hospital. That's more brand that's probably going to be more humanly oriented. And a lot of practices end up getting anesthesia machines from human hospitals. There's not a problem with that. Some of them are really great machines. But you can have 2 or 3 vaporizers. And it's common when you get an anesthesia machine from a human hospital that you'll have maybe a Sevo, an ISO, and a desflurane vaporizer on it. You know, in fluorine you don't find much anymore. But yeah, I mean, you can have 2 different vaporizers on there, and if you're in the ISO mood one day, you use ISO. If you're in the Sevo mood one day, you use Sevo. You need to have oxygen sources. Most practices now are going to be using the large tanks. These look like they're properly secured to the wall, chained, probably piped into a systematic delivery system throughout the practice, or directly to the surgery suite. We can use small tanks for backup. Either way works. The little thing they teach you is that righty-tighty, lefty-loosey. If you turn the knob to the right, it gets tighter. If you turn it to the left, it gets looser. Righty-tighty, lefty-loosey. If you mess this up, then you're a big goosey. There's going to need to be a pressure reducing valve, because the gas coming out of those big tanks, or even the little tanks, is going to be possibly at several thousand psi. If you run that into the machine, it's going to blow it up. So you're probably going to reduce the pressure coming out of the big tanks or little tanks or E-tanks or H-tanks down to about 50 psi. There needs to be a flow meter so you can regulate how much gas is going into the machine, how much oxygen is going out, and there's a fast flush valve, or just a flush valve, to be able to allow oxygen more rapidly to enter into the anesthesia machine. Really, the heart, the guts, the engine of the machine is going to be a vaporizer, because without a vaporizer, without gas, it's pretty much just an oxygen delivery system. Not that that's always bad. And there are times we use machines for that, just for 100% oxygenation. But the vaporizer is what's going to deliver, in this case, isoflurane. There is an inlet where oxygen comes in. Its primary function is to turn oxygen and liquid into oxygen and an inhaled gas, which is then going to go out the outlet. Precision vaporizers, there's precision vaporizers and there are non-precision vaporizers. Precision vaporizers are going to compensate for temperature, the gas flow rate, whether there's a lot or a little bit of oxygen coming in, and any back pressure on the system. The beauty of a precision vaporizer is if you set that knob at the top to 2%, you're going to get 2%. If you set it at 3, you're going to get 3. If you set it at 4, you're going to get 4. Okay? That's the beauty of it. You know precisely. Non-precisions, that's not always the case. There will be a unidirectional inspiratory valve. We often refer to these as one-way valves or flutter valves. And they make sure that oxygen flows through, the gas flows through the system in one way. We don't want it backing up. We don't want it going back and forth. We want it in a continuous circular fashion. And the flutter valves, which you really can't see in the picture there, they're inside those little clear plastic domes, are going to make sure oxygen flows the way it's supposed to flow. As you go through your reading, you'll see the other components of the anesthesia machine. There will be a negative pressure release valve, which will be there so that if the patient runs out of gas in the system, then air from the outside world can get into it and they won't suffocate. Okay, it's like, you know, holding a bag over their head, and once the oxygen's there and there's no gas left, they've got to have a way to get some air in. This is a way that it doesn't accidentally suffocate the patient. We're going to have breathing tubes, whether that's a Y piece or a single tube type of breathing system, like a universal system or perhaps a Bain system. We have to have the other flutter valve, the unidirectional expiratory valve, which is going to keep, again, with the other flutter valve gas circulating in a circular fashion, one-way flow through the system. We're going to have a pop-off valve. Pop-off valve can close the system, open the system. If we need to give a breath or sigh or breathe for the patient, we're going to have to close the pop-off valve, squeeze the bag, open the pop-off valve. Always make sure you open the pop-off valve. And then finally, there is going to be a pressure manometer. Pressure manometer is going to measure pressure in millimeters of water pressure. For example, when we sigh for an animal or we give them a breath, we are not to exceed, in a closed chest dog, 20 centimeters of water pressure. We can tell that by looking at the manometer. Rebreathing bags, they come in several sizes and they come in several colors. It's a rubber reservoir bag or a similar substance to rubber that allows the patient to rebreathe some of the exhaled gases. We all should be familiar with rebreathing bags by now. Tidal volume is the amount of air a patient is going to breathe in any normal, quiet, regular respiration. Certainly all the drugs we give associated with anesthetic procedures are going to depress the tidal volume. And we can use that to calculate minute ventilatory volume, which we'll talk about later, and some other factors that will help us in ensuring the health and safety of that patient. This is box 1-2 from your book. You can go through this. This is examples of breathing bag calculations. Okay, and we will get into some breathing bag calculations a little later on. This seems to me a little bit overly complicated and a little bit of overkill at this point in time, so you can take it for what it's worth. You'll start out in a lot of cases say, well, what size bag should I use, and you can do the calculations, and then it doesn't take you long before you just look at the patient. No, that's a 1 liter, 2 liter, 3 liter, 5 liter bag. You just look and you know. Certainly we need a carbon dioxide absorber or a SodaSorb system. This is located somewhere in the machine. Sometimes these come in prepackaged canisters, or they can be free granules that you add. They are crystalline in nature, and as they absorb carbon dioxide, they change color, turn this kind of purplish color. There are several different methods, different ways to know when to change them, because yes, they are exhausted. They absorb carbon dioxide, and eventually they are not able to absorb anymore, and if you don't change them, then your patient gets hypercapnic and it gets to be a real disaster. So you do need to change them on a periodical basis. Two ways to do it is by either color change or by time. I prefer time. I tend to have little checkoff sheets for the SodaSorb or the soda lime, and after each 15 minutes you check off, and when enough time has passed, then it's time to change the SodaSorb. It's relatively cheap. It is cheap insurance. Don't scrimp on carbon dioxide absorber. Extremely important that we have a scavenging system. There's two types. There's the active, which is mechanical. It's connected to a building source. You have a fan and it sucks the air and the gases and the anesthetics out of the room, out of the building, vents them somewhere appropriate. Active are better because obviously you're going to be able to get better reduction of gases in the anesthesia system and in the room and the environment. Passive systems rely on gravity. They work. That's my opinion. They don't work as well. It's important we check for leaks. You can develop leaks in that system faster than you can say jump back jack. You can develop leaks in hoses, in connections. Things can come unscrewed. Something deteriorates, something cracks. And with leak testing, we have to know when to check, what to check, where to check. We need to do periodical leak testing, or you're going to start end up inhaling and being exposed to anesthetic gases. Breathing circuits, there's several different types of breathing circuits we can use, different sizes, whether or not we are going to want to use a rebreathing or a non-rebreathing system. There are a couple of, there's 3 examples there: bigger hoses, smaller hoses, more pediatric hoses, and then one down below is what's commonly referred to as a universal system, where it's one hose, a hose within a hose. Those are the ones I like. I tend to use lots and lots of universal systems. I think they have a lot of advantages. Here are a couple of non-rebreathing systems. We'll get more into those in detail, the different types, particularly in the Thomas and Lurchie book, how we use them, when we use them. Non-rebreathing systems are for very small patients. These are for the pediatrics. There's different numbers. Anything under 7 pounds, you use a non-rebreathing system. Anything under 12 pounds, use it. We'll talk about that when we get into Thomas and Lurchie, but these are designed so that the patient, especially small patients, don't have to breathe against any resistance. It helps them to ventilate. They easily breathe in, and then when they breathe out, gases are vented. The bad news about non-rebreathing systems is they tend to dump a lot of anesthetic gases into the environment. There's just no way around it. But in most cases, it's such small amounts that we can compensate for that in other ways. Of course, there's all kinds of different ways to calculate your oxygen flow rates. A rebreathing system with patients greater than 7 kilograms, we're going to induce at 3 liters. Maintenance is going to be 25 to 50 mils per kg per minute, but never less than 500 millimoles per minute. I've seen people use 300 as the minimum. Recovery is going to be at 3 liters. Non-rebreathing systems, again, not that less than 7 kilograms. Induction at 200 mLs per kg per minute. Maintenance at 200 mLs per kg per minute. Recovery at about 200 mLs per kg per minute. Okay, and they get into large breed dogs and that kind of stuff. So we'll get into more into that in Thomas and Lurchie, but you're going to start out saying, okay, how much oxygen do I give them? Well, here, induce at 3 liters. Then later on, it's just going to become automatic. It's going to become second nature if you do this very much, and you're just going to be able to adjust it without thinking, by watching the patient, by watching the bag, by watching how much the system fills up. If you've got them at 500 mLs and it's not enough, then you turn it up. If you got them at 500 and it's too much, you turn them down. Not that big a deal. Other perioperative equipment that we're going to need to be aware of: patient warming devices. Certainly these patients, because of the nature of what we're doing, because we have body cavities open, because we're giving drugs that induce hypothermia, because they're not active, these guys get cold. And so we want to make sure that we provide supplemental warming or do everything we can to prevent them from getting hypothermic. That includes circulating warm water blankets, warm heated pads, the hot dog warming controller and blanket, and of course the forced air warm, which we commonly refer to as bear huggers. And when we're talking about perioperative equipment, well, there's surgery lights and there's surgery tables, because we don't get along very well without surgery lights and surgery tables. It's awful dark in those cavities, and that table sure does come in handy, especially if you don't want to use a kitchen table. That's a flat table. There are V tables, there are heated tables, there's non-heated tables, there are tables specifically designed for veterinary medicine. There are a lot of practices I've seen that are getting old surgery tables out of old human hospitals, and those are fine. Surgery tables are what you're used to, what you like, and most importantly, how clean you keep them. Okay, that's not so much which table you use, it's how you use the table you have. And surgery lights, many of them come with these handles that you can unscrew, autoclave, then you present them sterilely to the surgeon screws them in, and then they can adjust the lights without somebody having to reach over the sterile field. Reaching over sterile fields is a pet peeve of mine. I really don't like people that reach over sterile fields unless their hands and arms, perhaps their heads have all been autoclaved. Certainly we can use negative pressure suction devices. These remove fluid or air from surgical sites, most commonly going to be fluid, blood, serum, saline if you're flushing. They can be mechanical or manual depending on what you have or don't have. If you don't have a suction machine, not a big deal. A lot of practices don't use them. A lot of people think they're probably more trouble than they're worth. They always seem to be really temperamental and kind of cranky on times. And part of the suction machine is going to be the suction tubing. And for the last part of this section, there are suction tips that we use. There's a Poole, Fraser, Adson, Yankauer. That's one of those things that, some surgeons like one, some surgeons like the other, some surgeons like to use different ones for different circumstances. But that's going to be basically the equipment.